screening for all of them. So let's start this panel, and we are going to be co-moderating between Albert and I. We have called this session, Facts for an Ethical Integration of AI in Healthcare, which is, I think, a title extremely open. I should blame the organizers for this. You have a lot of work to answer the question. As I said before, I think that if I could make a survey about what are these facts, we must probably hear many different words and concepts like safety would arise for sure, and human rights would arise as well. But when we can say that an AI system doesn't harm, when it doesn't harm, what is considered, for example, an harm for an AI system in healthcare is a system that is precluding someone to get the right treatment. Is the AI harming someone for precluding the right treatment? A system who's worsening the relationship between the patient and doctor can be seen like an AI system harming or reducing patients' empowerment. Well, today is a great day. We are going to be discussing these very sensible matters. So welcome again, and let me introduce, and Albert as well, our 6 panelists. Cerdas, already with us before, former member of the European Parliament, shadow rapporteur of the Regulation on European Health Data Space, and rapporteur of the report on mental health. Thanks, Zara. Also, Chilvers, who's Deputy Director for Life Sciences and Innovation at the Welsh Government. Thanks for joining the panel, Rupa. Also, Dr. Sarah Markham, who's a visiting researcher at the Institute of Psychiatry, Psychology and Neuroscience at King's College London, and she's here as a patient representative. Thanks very much, Sarah. Robin Carpenter, Head of AI Governance. Before you were at King's with us, and congratulations on your new position. And he's now, as I've said, Head of AI Governance and Policy at Newton Street. Also joining us today, Beatrix Fletcher, who is an AI Program Manager and Fellowship Faculty at Days and St. Thomas's NHS Foundation Trust. Thanks, Bea, for being with us. And finally, Basab Bhattacharya. He's an AI lead and consultant radiologist at Barking, Havering, and Redbridge University Hospital, NHS Trust. Thanks, Basab, for being with us. Well, they were a little bit nervous because I sent them a message saying, oh, this panel will start with a surprise question. And they said, oh, what you're going to be asking? That's fun. That's not going to be difficult at all. But I think that Albert will open the turn of questions, making the first questions to Sarah.
Okay. Happy to do so. And the first question is for Sarah Cerdas. You are a leading voice of the fight against cancer. You know it. Should the current screening system in cancer, for example, the MAI software for breast cancer screening, replace human doctors?
Well, we have to say, this is a binary question. You're only allowed to say yes or no as an answer in a very short sentence.
So that was my question. I
Exactly,
can only say yes or no.
Yes or no, which is difficult, right?
I know.
And then just a very short
No, but they can complement. So that's my answer. No, but they can complement. I don't know if this is working. Oh, okay, it's working now. So that's my answer. No, they shouldn't replace doctors, but they can complement.
Great.
Good luck. Good luck.
As a social scientist, do you think that governments should regulate the use of intelligent chatbots in their health systems, as for example the Limbic chatbot, which is in use now? It's already in use.
No to regulation, yes to strict benchmarking.
And a sentence to
Benchmarking, okay. So I don't think we could regulate all the products by product, by what it's set up to do, because we'll be there forever. And government cannot do that level of detail. But what we can do is put guidance and standards in place with the organizations that are using it to say, if it doesn't pass a particular, we do this in cybersecurity, if it doesn't pass a particular pass mark, you should not use it, it is unsafe.
said in Markham, the patient's perception of the patient-centeredness of the interaction was a stronger predictor not only of health outcomes, but also fewer diagnostic tests and fewer referrals. As a patient representative, do you fear that the AI can put at risk the patient-centeredness of the medical interaction?
I think it depends on how the AI is designed and implemented, and again, benchmarked, and how guidance is created and also used. So I think it depends on so many ifs.
But yes or not?
Hopefully not. Hopefully not.
Thanks, Anne. So for Robin, Robin, we have been talking about the ethics of AI for a time now, you know perfectly. We have been in some other panels together, right? Do you think that the quick and recent emergence of generative AI is increasing the level of risk that AI entails for the population health?
I'm going to say yes. We don't tend to use it as a medical device, which means the risks are lower because we don't put it in such high-risk roles, but our frameworks are incredibly outdated. Like our medical device regulation is what, like 22 years out of date? So yes.
Thank you.
Great. For Beatrix now. This is a question about the national picture of AI in the NHS. There is a lot of conversation running on about the use of AI in the NHS, but is it ready to incorporate AI in a wise and efficient manner at the moment? If the NHS is ready to incorporate AI in a wise and efficient manner. Yes or no?
Yes. I think it has enough people in the system that want to make it happen, that if we came together, we could do it.
Thanks very much. I don't know if Basab, that is sitting nearby you, will be happy with this answer.
No. Is it wise-ish and efficient-ish? Is that wise and efficient? Wise and efficient. That's the thing.
Right.
Wise and efficient. Anyway.
Actually, your question is quite related.
Yeah.
I was expecting this.
Wise and efficient.
So, do the NHS staff have an interest in using AI if no extra incentive is provided? Yes or no?
Yes.
Very good. And
I've been given my orders. I follow my orders.
what's your justification for this very convinced answer?
Once again, for example, let's look at the mechanical... my hospital has a mechanical thrombectomy pathway, and when that got set up, I was CD for setting it up, and we were looking at things like AI, for example, brainomics. I didn't actually believe it had a role, because I was like, I have INRs, I have neuroradiologists, why do I care about it? Then that came to disastrous halt, because middle of the night, you've got to look at that. And then I was like, fine, teleradiology. That was going to be a bill of about 300,000 a year. At that point in time, I started panicking and collapsing with laughter. So then with AI brainomics, that allowed optimization of that pathway to stratify patients to yes, no for mechanical thrombectomy in a very easy way. Some of the INRs really didn't believe when it got set up, but because it could be seen to be smoothly integrated in a path. Once again, I held no torch for brainomics. I think, it does the job. But anyway, because it was seen to benefit a pathway in a resource positive manner to allow appropriate resource utilization in a time-sensitive manner, people adopted it because it was intrinsically positive. There are some other, so for an AI adoption, it really depends on the AI tool and how it's implemented in a pathway in a way in which makes sense to the individual nodal points in that chain. Does it all make sense?
Yeah, totally. Thank you, Basab.
Thank you so much. And we should make a start of the dialogue between all of you. We'll start with regulation. We've seen this recent manifesto on advancing trustworthy AI. We've seen many initiatives coming from the EU, like the AI Act. We have proposals coming from the Council of Europe. We have proposals coming from the G7. We have proposals coming from the OCDE. But don't we need a global regulation on AI? What do you think? How this international initiative could be translated into real actions? And do we need a global thing or not?
Yeah, okay. In a perfect world, yes, and it's doable. So if we look at medical device regulation that we have now, that was born out of World War II. Economies were destroyed because of World War II. So we got the Treaty of Rome, which was a way of us working together to be able to sell, to be able to have the same standards, to know that all are good enough. And that really boosted all of our economies and economies beyond the EU, including the UK at that time. So it showed it's doable and it's operationalizable. But having everyone speak the same language is incredibly difficult, like not just within the nation, because our different regulators speak different languages, but internationally. So if we look at the US right now, obviously Trump is coming in, so their tech policy is going to change. We're going to get Senator Cruz, we're going to get Musk, and that's probably going to be a very different flavor for the FDA and everyone else in comparison to the EU and the UK. So doing it in practice is becoming increasingly challenging, but it's doable. We've done it before, at least within the West.
And what you said about people understanding each other, having a shared language, it also, that an added complication is people, different countries, different agencies and agents have their own agendas. So that's another added complication. But where that has been a long time a challenge, and there's been a great deal of learning, is in NATO, because in NATO, although it's a military organization, you're getting a whole number of countries often coming together, often in the context of multidimensional military operations, and they've had to face and work with that kind of communication and mutual agenda challenge for some time. So learning could be found in NATO.
Yeah, you can.
I wanted to come from the perspective of why we've ended up with bias in data, and that's because we haven't enabled communities to get involved from globally. And so if we do have a global perspective, I think what we do is give a currency to countries that are ready and able and perfectly willing to get involved, but don't have the resources and ability to get involved in an international stage because they are pushed out. And they're pushed out because they don't have the level of investment that we have. So I think if we take a global angle, we start to look at equality a little bit differently with a lens, most importantly, bring in the communities that are lesser involved in this area at the moment.
Yes, I think we need a global framework. It's doable. Yes, we have several examples of how it can be done. Currently, at the global level, one of the global accords that's being discussed, we still haven't reached an agreement, is the pandemic accord, because people already forgot about COVID-19. Sorry, I laughed, but people already forgot, so there's not much push for it. But the way that policy or politics work is about the demand. So it's important also to understand the policy cycle. And I think now that there's a growing demand on it, it can be the opportunity needed for us to advance that global accord that you were presenting on your introduction. So I think it's doable. It will take a lot of effort. Now with the recent political developments in the US, it's going to be harder, but it's not impossible.
One thing that I have to question is, what's the point of having regulations if there's no enforcement? Because you have global regulations, how are you going to enforce, for example, in areas in which, let's just say China, they've got their open systems, their open models there. How are you going to enforce it? If you enforce it only in, let's say, the EU and UK has significant enforcement, what's the point then? Because if you just make regulations but don't enforce it, what are you actually doing? That's one that I don't understand. So that's one thing, because otherwise it just becomes performative, doesn't it? So that's my main issue about it. And it becomes performative and really only followed in areas which would really follow it. And another thing about global standards is that, once again, we can almost look at what's going to happen with Trump and climate. They're almost going to certainly go out the Paris Accords, but that happens every time there's a Republican president, isn't it? They go in, they go out. So trying to do too much effort into a global set of standards can depend on too many variables. And also, what about the sanctions? Otherwise, it's just paper, isn't it?
I wanted to pick up another point that Sarah mentioned. You said policy is made on demand. What we have seen with the AI is like a new paradigm that things are running that much that you are coming like behind, and that's everything very quick. So can governments really adapt to that quickness and be on time to regulate things so that they are not being arming people? Because we are already using generative AI on the medical sector with clinicians using it to upload pictures. We know that this is happening, right? Which is not obviously, well, they are making the big problems on safety and security and everything. So that's already happening, and that's not regulated at all at the moment. So how policy can really jump to solve the problem?
I can reply to that, which is that governments really need to be sensitive that this is already the reality now. I was just now in Lisbon for the European Public Health Conference. They had an AI plenary session where they asked, in the past week, how many times did you use any AI tool? More than 70% of 3,000 public health professionals in Europe stated that they had used it. So it's already a reality, and that's one of the things we did with the AI Act. We tried to make it faster. Now it's up to the national governments to implement it. Regulations in the EU, there are actually laws, but international regulations, it's not. It's just to distinguish this nomenclature, because we use the same name, but regulation in the EU is law, but international regulation is not enforceable as such. But governments cannot fall behind. But I'm a bit skeptical in that sense, because governments are now reacting a lot on the, we call it in Portuguese, the foam of the days. So very superficially, so in Portugal now it was a problem with DR, emergency doctors, and so now all attention is on that, and AI is more of a big thing, and I hope they are reactive and they work fast, but I'm not so sure that will be a reality, because now they are all trying to survive with this boost of extreme movements, and them coming to government where this, for all of them, this is not important. It should be liberalized as much as possible, no rules whatsoever. So it's going to be interesting.
Robin.
So the question was, can government keep up? And I think it's important to highlight that no law will ever be perfect and it will always be chaste. So if we take data protection law, we have obviously GDPR, which came into force in 2016, but that was on the back of 4 decades of data protection law. And the wording wasn't a whole lot of difference between those 4 decades. And still we have the Working Party 29, the European Data Protection Board, that are answering questions about that. We will always be chasing the new questions that come out, and that's necessary because the world changes. And we're in quite a good position in the UK because we have a common law system, so we can have common law created out of case law, so where it's easier for us to catch up without going through the whole parliamentary system. And I just want to jump on your point of like, what's the point globally? And I just want to highlight, from my perspective, it's not binary, it's a spectrum. So if you look at, again, GDPR, the difference between the way Germany and Ireland enforce it is huge. It's almost like different regulators, but both are following a set baseline. And that is a good argument for doing it, because we're at least creating a floor for it, and then other jurisdictions will do it better or worse, and then we can impose like trade tariffs and things like that to try and create some sort of incentives. So I just don't want to throw the baby out with the bathwater by saying, well, what's the point? I think there is some good to it.
I think if we are going to have sort of a global policy, we also have to have a slight change in how sort of the, I guess, to use your word, the foam is making its way back up. So there has to be this sort of constant reviewing, constant changing of what that baseline is in response to the environment. And the only way for that to happen is that for both things to be dynamically alive and communicating. And I think we don't really have that like perfected yet. We sort of have these stages where people sort of say, I'm going to make a decision about this particular thing, I'm going to go find out this information and talk to the people relevant at this moment, and then we're all supposed to just follow that, and then it's a long time before the next one. So I think we'd have to sort of change how we develop these sorts of, what the global opinion is on the baseline.
And I think also, especially in democratic countries, it depends on what's important to the population, because the population is ultimately people who choose whether or not someone is in power or stays in power. So it depends on, wider public understanding of the issues and what is potentially at stake. And also governments being aware of this. So it actually, motivates them to engage.
No.
I was just about to say, I think it depends really upon the healthcare economy. For example, in the UK, we're quite a controlled, centralised NHS system in which, so by default, it's more limited for patients to get for unfettered access to AI. And that can be an issue as well, because it massively slows down development of AI dependent on NHS trust, whereas compared to the US, where they have genuine madness there, with genuine sane devices which make very little biological sense, but the market wants it. So I do think in the UK, concentration on standards combined with relative centralisation of healthcare means that there is a good way for not the government to be ahead, but to control the pathway with funding and increasing emphasis on education and standards. So I think it's relatively better in the UK than other places potentially.
I think the only thing I would add to that is we shouldn't just see AI in a silo. So in terms of medical technologies, we know it's going to overlap with what we do in pharmaceuticals, for example. And what do we need to do as government to protect people when that happens? We're talking about that right now. So I think we are in danger of just going into a big hole that's AI and then forget it, and then not actually coming up the surface and actually going, this is happening across the board, and there's a few levels up. So, for example, in Welsh Government, when we talk about it in health and social care, we're back up to our government colleagues and going, what are you doing in aviation? What are you doing elsewhere? And trying to learn from that. And I think we do have to be careful, trying not to create policy for policy's sake when we don't need it.
This is a very good point. We need to avoid silos. We've been talking about AI regulation, data spaces regulation. What about cybersecurity? How relevant is it from your point of view? Is there a room for international cooperation? We were talking about NATO. I know NATO wants to focus on cybersecurity as one of their main elements of their future strategy. What do you think? How relevant is it, taking into account that several hospitals have been hacked and very sensitive data have been released? It was the case in Barcelona just 1 year ago, I think, Hospital Clinic, one of the main hospitals, and it's been the case in many other cities. What do you think about this?
Again, I think this is dependent on relations between states, because if a given state area regime thinks it has an interest in hacking the healthcare system of another nation, then it is going to be less likely to engage in any meaningful way internationally with partners. So I think this kind of reflects a need for real incentives for all regimes, globally, to abide by, codes of practice, and where relevant, share information about cybersecurity in an adaptive way. But this depends on those relational issues within countries and between countries.
What I'm going to say might be a bit, I don't know. But I think that the warfare has changed. So we had World War I, World War II, and perhaps we might go into, or not, the Third World War. But perhaps that war, it's not on the ground with bombs, as it's happening just in our gardens in Ukraine and Gaza. But it will also be about data that can be translated to information. So if governments need to acknowledge this and need to see for instance, use NATO as the framework to also enforce better cybersecurity. White hackers need to work for governments, with governments, to ensure that the data of citizens, which is quite valuable, doesn't end up in the hands of those that are going to use it for other purposes than those that the data was intended to. So that's my perspective, that the warfare has changed and we need to be prepared that there's going to be Russia, China, other countries that can have different realities or different, can be behind different cyber attacks, but the governments need to be prepared for that, because that's the reality that we have now, and with AI it will be an even wider reality.
I think that's a really great point. Is there to add something else on this? Just related to what Sarah was saying, then is our government here in the UK taking the necessary steps to protect people's health based on these risks that we are saying? What do you think?
Are you talking to that?
Robin, yeah.
Sorry, can you say that again?
If it's our government really taking the necessary steps to avoid these risks on cyber attacks that, for example, Sarah was mentioning.
Well, it's hard to say because a lot of things happen behind closed doors, right? We do take a lot of steps that we aren't publicly aware of. We do have a baseline standards. Those baseline standards aren't arguably that dramatically amazing, like cybersecurity essentials. That's what you see everywhere. It's not really, it's not really all that. I think we can only go so far right now within the NHS of how much our infrastructure allows us to go, and it's all pretty outdated. And I do agree on the points that we've had before, that we should have some kind of international collaboration like we have had. So like our UK security agencies do work with NIST in the US right now to try and share standards. But there is also a precedent to always having your own national security frameworks that don't necessarily collaborate with other jurisdictions. I mean, that's always, if you look at any international binding law, there is always scope for you to set your own standards for yourself. So I think there will always be a space as well that we have to set what we think is best, but also collaborate and try and learn from each other in a way that still protects national security.
So I think when we think about cybersecurity, I always go back to the workforce. So are we doing enough? Maybe not enough at the pace that we need to. But it's a constant dilemma in terms of the resources. So when we make an argument to say, actually, we do need to pay attention to cybersecurity or the digital infrastructure or the training of the workforce before you go to the next level, it comes back to the conversation we were having about whether we'd slow something down far too much. But that is if we can make a global effort in terms of thinking through the way our workforce is trained today to make sure that we can get topics like cybersecurity into training. That is what we need to do today. We need to be training them with the technologies of the future, and we're not doing enough in that space. So if we keep putting all our focus into today's hospitals and GP practice and community care and whatever it is, and not think of who's coming next, we will be in danger of this. So I think we should do more in that space.
I would like to move now to another aspect that I think that is very relevant for regulation as well, which is accountability, responsibility. We know there has been publications on this matter that clinicians, one of the things that are fearing clinicians especially is about who's accountable about particularly a wrong decision provided by an AI system. So who's accountable? That's the question, and how we can regulate that. What's your point on that?
Oh, can you hear me? Yeah, so this is something that, because right now in my hospital, we're using increased amounts of AI for image interpretation, and with things like that, for example, with CT bleed interpretation, my policy is that it's similar to, let's just say you're doing like with ultrasound-guided punches of the vessels. You can use it or you may not use it, but it's something that you should use, and the accountability is still with the doctor. The thing that I think is more of an issue is when, for example, when you have chest X-ray AIs and it has an abnormality, and you then report that, but then that AI, that secondary capture image then goes back to the main packs, and you have ED doctors looking at it as well. Who's accountable for that? Because that then messes it up then. Do you see what I mean? So I do think that's the thing that complicates things when you have tools. I think fundamentally, it is all, with things like computer vision related AI, it is still medical personnel who are accountable for it, but it's getting things messy in relationship, particularly when you have a tool and you have different specialities using it and that can blur it. So I think that, once again, comes to education, but the accountability will always still lie with the doctor, and I don't see that ever changing, and that should never change.
So my opinion on that is similar, but maybe slightly different. I think that it really, I agree that it totally depends on what the AI product is being used for and at what point in the pathway. And when you talk about like an AI decision, I mean, we don't have that many products in practice that are, you know, making this point blank decision on this is what's going to happen to this person. And more often it's included in the other points of information that any clinician would use, as they do now, to sort of get a picture of this patient and how we might treat them, what might be the best course of action, and presenting that. So I think, you know, in that way, that there is sort of accountability of what pieces of information you're gathering. But then equally, it's a tool, and it's something like, you know, how we would see a scanner or a stethoscope or a blood pressure machine. Like there's certain accountability that comes from within the trust that manages those medical devices. And so I don't think it's all on the doctor, but there are, or the clinician, I should say, because it's not just medical.
I think one of my other fears is that care's now got fragmented. Like when I started out in medicine, you were on take and you were always on take with your team and you were all together. Now it's gone fragmented. No one has their own doctor. A patient may be seen in ED by a locum junior doctor who then may go off shift, nothing is chased. And then you've got that AI result and people then act on it. And for example, like one of the areas that AI is being looked in for as a positive case in the US is, for example, in family medicine, with a lot of physician associate being under a family physician, and they'll be augmented by AI. And this is going to be like a massive, almost augmented AI farm. So where is that going to lie with the clinician? Because they're almost completely dependent upon the AI. And there's no, and the previous noted continuation of something as a fully qualified person isn't there. So my concern is that the automation bias may be massively increased. So particularly in areas where there is no oversight for financial reasons, particularly in areas like there is, like in part of, like here, for example, in the northwest of the UK, there's been massive issues with recruitment there. And I can see that happening there where you've got a lot of AI augmented, non-medically qualified individuals, and they'd just be dependent on them and then be having oversight by one doctor far away.
I think, sorry, to come back to you. I think that often when we're discussing these topics around AI, we think about all these issues and we say, oh, we shouldn't use AI because of all of these issues. But actually, all the issues you're describing are nothing to do with an AI's performance or utility, and actually much more about the system around it.
I know, but it has to come together, because I've done, with AI deployment, I've seen the AI be deployed, but no one's ever thought about that, and then it becomes a mess. And then you're just scrambling around it, then you're in a contract with a company, that's a pilot contract on their little like introductory bond, then it gets rolled on, then you've got, and so this is why you've got to think about all of it together.
Yeah.
I think we do need to step, I think everything you've said is correct, but if we step one up, because we can't do this technology by technology. So we have clinical safety officers, for example, as a requirement in organizations to sign off on some of these deployments, right? So what we try to talk about is how can they share information across organizations, and it's a tough ask because each context is different. So if you say accountability, at some point the chief executive is accountable. That's the end line here. But that chief executive has to put in, and then chief medical officer, if it's medical, they have to put into place processes. And I think that is what we will end up relying on one day, differently to the individual accountabilities that are running through, because it's slightly more immature. But I'm not saying it entirely removes it. There's a layer that clinicians and practitioners should depend on, that their organization has done on their behalf, that isn't totally happening all of the time today.
And then Robin.
And again, it depends on how much is known about the tool, the technology, and its limitations. And can people, what happens if, if there is a kind of an adverse outcome for a patient or patients in the context of clinicians using this recommendation or this result from a tool, how can it be gauged whether or not the people involved, had the wherewithal or should have had the wherewithal, the competency to identify this as a potential error. And that can depend on so many variables. It can depend on the developers' understanding of the limitations of their tools. It can depend on how that's communicated to organizations and practitioners. So that's another dimension to factor in.
Robin.
I think this is a really interesting question because right now there's a lot of smoke and mirrors, as in when you put something into the market, you have to have a use statement. And you say you can only use by these people in this certain way in this context. And that sets pretty clear guides of who is responsible in that context. So we know right now with most products who should be responsible 99% of the time, clinicians, someone in the NHS. We also know that we're eventually going to a place where we're going to try and fill in gaps with automation. I have hospitals talk to me all the time about this. How can we do it? And what's interesting about both those scenarios is we know that all products can eventually drift, whether that's because of somebody becoming biased, as in relying on it too much because the data set's changing because there's a new scanner, because of something else. And we don't have any infrastructure to check for that. So there's this massive national, international push to put all AI products in, or loads of AI products into the healthcare system. But we don't have any monitoring dashboard to say, okay, these things are drifting, now we need to check it. We have clinical governance frameworks, but how much do we actually check a product? Like, what, once or twice a year? So there needs to be an infrastructure push if we're going to get to where we're hoping to get to in the NHS and where the NHS is trying to push towards. What I think is really interesting as well is what happens when it drops out. So we have some case law where, for example, there was a case in 2021 where there was a clinician, unfortunately, because of a host of reasons, but one reason was she couldn't access the blood results because the EHR dropped out, a child died. And then that fact that it dropped out led to the death, but didn't necessarily impact the ruling of the case. And so we might find ourselves in situations where we have all this infrastructure, we can use it, but we're not necessarily prepared for the day-to-day situation where we suddenly are relying on it and we can't use it. And I think that's interesting because case law from 1250 has always been developing. We had case law and then it became tort law and it became negligence, trying to find out when someone is responsible for harm. And that's going to continue going for the rest of our lives. So it's an ongoing conversation. It's kind of clear now, but it's going to get less clear.
Let me now put a quite provocative question. I know 10 years when it comes to AI is a lot. It's like ages. But we need to anticipate what may happen in the future, especially when we're talking about regulation. Tell me, what's your idea how the role and the job, the specific job of doctors may change in 10 years' time?
Sorry.
You go.
I think the doctor's job always changes. That's the thing what I don't quite understand. For example, people thought that with PPIs, upper GI surgeons would be out of business because that's what they did all their gastrectomies. There's lots of upper GI surgeons. People thought that once we did scanning, there'd be no point touching a patient. That doesn't happen. Medicine always changes. So I think that's why I do think it's still important to have a general medical practitioner that's broadly trained, because you have to be adaptable. It's just simply a tool, and you will either adapt or die. And that's why I do think this is why I do think it's important not to be, to anyone who's in medical training, don't be overly specialised, because then you're making yourself a hostage to fortune to a certain extent. I don't think AI, and speaking as a radiologist, I know Geoffrey Hinton said that you should stop training radiologists in 2015. Good luck with that. If you look at the actual training ratios, radiology's gone sky high. So I do think there will still be doctors, they will still be using AI, but you'll just have to adapt to how it changes.
I think part of their role will start including kind of what Robin was saying, in that sort of surveillance and monitoring of the performance of the product. how is it working on my patient population, how that evolves, being more involved in those discussions on what products should be brought in and which ones should be retired. So that's what I see for the future of sort of a clinician, an AI-enabled clinician in the future. As I said, pulling different data points from different places to make that decision, but probably to be more involved in those aspects as well.
Can I just add a sort of almost counter-2 point? I think it's actually more important for clinicians in the future to be actually more hands-on, because we've now got a situation where, particularly junior doctors, I don't know if you, they spend a lot of the time for different reasons, not as hands-on as when I was a lad years ago. And I think a lot of the role of AI tools, it depends on the pre-test probability of the patient assessment. And I think the role of the doctor or clinician, but you know, I'm speaking from the viewpoint of doctor, in assessing the patient, getting grips with the patient, is where everything, because I've seen lots of assumptions made and people going down an entirely slightly strange diagnostic viewpoint. So I think counterintuitively, although it's important to be aware of data sciences, I think it's actually more important to really make a push for getting clinical skills and hands-on training for our juniors much more to the forefront. I think that's been unforgivably ignored for different reasons over the last 10 years.
I think I'm wondering if, and I'll go beyond doctors in terms of thinking about clinicians, practitioners, whether they could have a layer that is actually looking after their patients for them. So when I say a layer, so at the moment we have a project, and it also happens in England, where you can connect a paramedic to a specialist through video and on site. So the conversations that are happening for stroke specialists at the moment, for example, is they're in clinic and they might get a call from a paramedic. Well, our GPs were getting that before, but maybe not a video call. So they're layering on a new way of interacting with yet another professional. So I wonder what we might create is that sort of opportunity to use the data to layer on a different type of practitioner clinician who's going to help, who's going to be the person who helps the person having the one-to-one interaction. And maybe what we really want is more relationship-based care, which is what every practitioner and clinician wants, that gives us better data, that gives us better insights into people. And then I'll go into precision care, medicine, and then the care that can come from that. So what I'd like to see is a multidisciplinary team effort that comes off the back of tools like this that can actually say we are better at what we do in health and care.
And I think within that, I mean, especially following down the MDT approach, you know, including the patient in that, you know, following the NICE guidelines for shared decision making. And, you know, in order for that to be effective, in effect, patients have to change. What can support them, you know, to adapt. And I think at that we need much more education and awareness in schools about how AI functions in the healthcare system, and also public knowledge as well, and for it to be a part of, in effect, public health.
Yeah.
So it is obviously inevitable that the profession will change. Like your role 2,000 years ago in ancient Greece would have been closer to a herbologist than what you are now. The problem is, as you've alluded to, is the training standards. So there was a study that was released a month ago where they looked at Nigerian clinicians, and they found that they got 84% of them got their information about AI from the internet. It wasn't built into their training, and it's not much better across the globe. There's loads of global studies looking at different jurisdictions. But it is taking it back to the whole point of this conversation, ethical AI, it's an ethical imperative, because to maintain patient autonomy, we need to be able to describe what's happening. And to be able to describe what's happening, that's generally going to come from the clinician. And for them to be able to do that, they need to have the information provided in something like a model card saying these are the limits of the product, this is how it should be used, but then also being able to understand that information and communicate it in a patient-friendly way. So it's going to happen, and it's necessary for it to be done the right way, but globally we're nowhere near where we need to be.
We hope that it is happening before 10 years. Because actually, I'd like to finish with another binary answer question, and that will be the end of the panel. This one is the same one for all of you, okay? And I would like to hear from you if you think that we have been discussing a lot about regulation. If we have enough regulation at the moment in the healthcare systems in general, particularly across Europe and the UK, so that the use of AI is supported. There is at the moment enough regulation so that AI can be implemented at the moment in the healthcare systems across Europe and the UK. Sarah?
At what level? Like in a clinic? No.
Rupa?
Yes, but not enough standards and guidance.
Again.
What did you mean by revelation?
Well, if you think that the use of AI by clinicians is regulated or not,
Yes.
I would.
give an explanation if you want.
No.
Robert.
I would say yes, but so for the last 5 years, I've had clinicians and companies and academics come to me asking me to explain regulation. So the guidance and resources accompanying it is nowhere near good enough. But the regulation, yeah, it's good enough to hold us above water.
Yeah.
As someone that often is involved in making the regulation a reality, I'm going to say no, because I would love to say yes because there's so much, but it's just not there, you said, to support clinicians to adopt and use this, and I think we're sort of missing those interpretations or practical guides or a how-to. So yeah, that's my...
So similar thing where I'd say yes, but I don't think anyone's actually following it, because each NHS trust is fundamentally, once again, there's no real such thing as the NHS. There's NHS trusts and ICBs, but they're like, I don't have to care what the Royal Colleges think of me. I just have to do what my NHS trust is happy with me doing. And because it's coming up to winter and all the clinicians are going to be busy, everything's going to shut down again. So yes, but do people know the regulations exist? Do people follow them? So that's my main issue.
It was almost half-half, I think. 50%. Well, now it's time for the Q&A. So now it's the moment for our public to make any questions or comments to our panelists. Thanks very much for the very useful insights. So is there any comment or question you would like to do? So please raise your hand. Yeah. Lei or Nabila are around with the microphone. Thanks, Lei. There's someone there in the last row, yeah. Far away.
Making them work.
Run.
No.
Cardio up. Things cardio up.
Hi, I'm Bhattacharya. I'm a GP registrar and clinical AI fellow. So my question is sort of a two-parter and slightly controversial, but I hope this is a safe space. So the first question I think is, increasingly, I mean, we know that doctors are held as the kind of gold standard in terms of maintaining the ground truth when it comes to verifying an AI's output, whether that comes to like clinical decision support and symptom checkers or imaging or pathology. And I guess my question is, going forward, how do we maintain a cadre or a cohort of doctors that are able to, I guess, objectively, dispassionately verify the AI's output without being susceptible to like automation bias or confirmation bias, and sort of can say like free of any of the biases of what AI is telling them, whether something is sort of correct or incorrect. And then secondly, I guess taking a step back from that, is it even correct for doctors to be regarded as the ground truth? Because increasingly we're saying that AI is performing as well, if not better, than human benchmarks and human outputs. So is there a paradigm in the future where actually AI is the gold standard, or AI is the benchmark to which humans can aspire to meet or exceed? So yeah, I guess two parts.
Who wants to take?
Big questions.
Fine. Okay, no, so with the part for your first part answer, there will be, because I've observed this with AI deployments here in my hospital, and it's about automation bias and loss bias, because no one will get in trouble for saying that a scan has a bleed and then do something about it, because if it isn't a bleed and you're wrong, it's like no one gets fired for buying IBM or getting McKinsey. And particularly in ED, with the current political climate of blame, which still does exist, and AI tools, if it shows there is an abnormality, people will go to, similar to that chest X-ray example I gave. So I do think it comes down to education. For example, like on a lot of the intracranial hemorrhage AIs, a lot of the times, particularly I work in a neurosurgical center, a lot of its positives are post-surgical bleeds. So why would I care about it? A lot of the times it's meningiomas. So if you don't have a baseline education, you can be misled. So, but I do think it's about educating people and allowing them the freedom to make a clinical decision and be wrong and support them. But that's a broader context. With the ground truth aspect of it, I do think, once again, currently, like particularly in computer vision, AI does really now one scan modality and most of the time do one pathology, though you do get them grouped up. So in medicine, you're just not treating the image, are you? So you're treating the patient multifactorially. So once again, it comes down to the level of education of that clinician to make sure they're seeing the entire pathology of that patient and using it as a tool. I think there may be a situation in the future where AI becomes more encompassing, and that would be more interesting. But for now, it depends upon people simply not just treating the image or the result and keeping still an awful word, holistic view of the patient. Does that all make sense?
I think it also, looking in a wider context, there's opportunities perhaps for clinicians to learn from AI. For instance, diagnostic tools. A tool might pick up something that they hadn't noticed or wouldn't notice. And when they look at a scan or whatever, they think, yeah, that's right. I could have noticed that. I'll remember that. I think in a wider database context, it's interesting how AI may either be designed and also organized, both at the individual and more connected level, so that devices can learn or data can be captured when the clinician disagrees with a result. And in the context of more federated data sharing, how can that be done so that in effect, on a wide scale level, algorithms can be retrained either locally or centrally via federated data sharing?
I'm trying to imagine from the example that I gave. And in that scenario, what we're being told is that the human is overcautious, if I put it that way. So sending someone into the pathway to then have various diagnostic interventions when they don't need to be in it. And that's an interesting one that's playing out because that isn't where the gold standard is the human in that conversation. I think what I'm struggling with at the moment, and will play out in the next 5 to 10 years, is when we start to have enough data that says because of the depths in which AI can go, that the human can't go, that it will override the human correctly. I just don't know where it sits on the pathway in terms of impact. So will it eventually tell us that we have over-intervened? We have taken out an organ, for example, when we didn't need to take it out. Mm-hmm. And I think that's when the implications get really serious. I think while it's putting someone on a pathway who then has a test and the human is still in the loop and we have other diagnostic measures as a gold standard, we're fine. I think it's when we start into the intervention zone where an AI has made a decision or human has made a decision. And I think that will play out in everything you're talking about in terms of data, and it's a space to watch.
So on the first question, maintaining a doctor that's good enough isn't too subject to automation bias. So we Newton's Tree, sorry to talk about the company, you don't like it, these kind of things, but we're building a dashboard and that's one of the things we're looking at, is how much they agree with the algorithm to know what automation bias is coming in. And that's the way to do it, but that comes with implications. So if you look at the Institute of Future of Work, they look at people across sectors being monitored. It depends on how you're doing it, whether it impacts well-being. And we don't want to monitor people in a way that's going to impact their well-being and make them dislike their job, especially in the current ecosystem that we're in. So I'm interviewing clinicians to see the best way of doing that. But I think that's the way that you address it. Because the alternative method that people often say is that you throw curveballs every now and again at someone without them knowing, and then seeing if they are subject to automation bias, which I don't think is a very great use of time, because then someone will be triaged off to a place they shouldn't be. And as for should doctors maintain as the ground truth, one thing that makes me really nervous about that, with AI becoming the ground truth, is getting into a place of exponential technical debt. I think that would be a bit dangerous. But also the fact that there are certain things that can't be quantified about a human that a doctor will pick up. And so I think there will always be a better data set if you finish with a clinician that's informed by the algorithm, as opposed to purely relying on the algorithm.
So I've taken great interest in looking at adverse event reports for medical devices that happen to mention AI. And what I found is that almost none of them, at least in the US, the European FDA, almost none of them actually mention artificial intelligence or machine learning. That's really puzzled me, because I'm thinking, is it that they don't exist and don't happen? Is it that they're not being reported? So I turned to this discussion, and I think in the context of diagnostic services, which would probably be classed as medical devices, what is your feeling on the ability for all the people in the food chain involved with this to report adverse events, saying, I've used this diagnostic tool, and I think there's something fishy going on? How has that permeated the sort of health ecosystem? What's your confidence of thinking whether you think you've seen it being implemented, or do you think you just never hear about it? Or what are your thoughts on that?
Yeah. I'll jump in first. So we have systems for it. We have the yellow card system, where clinicians or a patient could share information with the regulator, and we have post-market surveillance for medical device, where they should be recording that kind of information. But to your question, is it done well? No, absolutely not. The gold standard of post-market surveillance normatively is people sending out surveys every now and again and having feedback mechanisms, which is, that's not going to pick up most of what that is. And I know this by directly speaking to regulators in different jurisdictions, that it's just, no, it isn't done well.
I think it's also difficult to pinpoint if it was exactly that tool only, in that decision only, that led to this incident that was significant enough for someone to report it back. I think we need to get better at tracking that sort of downstream impact, and I think the other panel members mentioned that in the future we'll start getting that sort of feedback again on and possibly an AI's interpretation of a clinician's performance based on the advice it gave it. So I think, yeah, also I do think that regulation is quite limiting, and I think there's a lot of, as Robin said earlier, about like a use mission or what this product is meant for. I think at the moment the companies that are the biggest players are quite particular on that, and so exactly for that reason, so that they can't get pinned to be the reason for that incident. So I think maybe that could be playing into it.
And I think also, given the complexities you've identified, where it's not necessarily easy or straightforward to identify a root cause and whether or not it was the AI, how can reporting kind of incorporate fuzzy thinking, where there might be an ambivalence? And how can people be, again, it's education, supported to be able to report that in a meaningful way?
And I think I would just add, yes, we don't record this enough. So even if you say at a national level, do we have a full understanding of all the AI that's in the system? No, because it's not a drug. We don't have that line straight in that's regulated as tightly as who is actually going to give this drug. We don't have that for medtech. So it's not an impossible ask, but it's a really fuzzy area in terms of what we need to do. And I think some of our conversations at national levels, what do we do for the high risk? What do we do for the high impact differently to others? And then also, what do we do to be pro-innovation and support people to keep bringing in these technologies that may, in a safe way, be deployed and looked after, which means it won't necessarily hit those reports that you're talking about, but internally it's being monitored. So I think there's something about what's being held internally versus what's being held externally that needs to be remembered.
Final comment, the initiative. Anyone would like
Just about that thing, for example, like, about the one main issue is about seeing people using the AI device, because the human is actually, in many ways, a weak point. For example, in my hospital, we bet for one AI computer vision tool, we barely get an obvious feedback, whether it's false negative, false positive, of barely 20% of all ones. And if anything, I've seen more issues in the last month by people sometimes not using the AI tool at all. So I think it's the issue about having the resolution of follow-up to then go downstream and then say, this is what the issues is, this is potential harm. If I'm honest, I've seen more harm in the last month from people not using an AI tool they have available than using it. And it also depends upon who, and trying to, and it's ridiculously hard trying to get that into people's heads about how to ensure they are giving feedback on whether the AI is working or not. It's beyond belief how difficult it is on a really educated background. Like, this is not this is a slide tool, but in the first 3 months of using an AI tool, we had barely 50% of consultants using it, 60% after 6 months, and after 9 months, maybe 90%. And this was workshops, so it's difficult. That's the bit, the bit to get feedback is very difficult.
Well, I think that we got a very, very nice description of the whole picture at the moment, guys. In regulation, the possibilities of using and implementing AI at the moment, and about the need of education and empowerment. That was really, really helpful and informative. I would just ask for a big applause for Sarah Cerdas, Chilvers, Sarah Markham, Robin Carpenter, Beatrix Fletcher, and Basab Bhattacharya. Thanks very much, guys. We can see now some of your main, the main ideas of your panel now in our screen from our infographics designer. You will be able to see it in a minute. And in the meantime, time for lunch. So you're all welcome to join us for lunch. We will be back again at 2 o'clock, and then we will start with 2 more talks. So, wow, this is really crowded. You've talked a lot, actually. Who's responsible? Regulation, take a role that will evolve. Very nice idea. If AI harm, the challenges of AI, well, you can see all your ideas in the very nice infographic. Thanks, Javier. Great. Time for lunch, and we'll see you in a minute. Thank you.